Hello everyone, welcome. I'm Dr. Shariful Halim and today let's talk about Horner syndrome. So Horner syndrome is a very important discussion topic for USMLE Step 1. It's commonly tested and can be tested in your respiratory system, respiratory pathology, and it can be tested as a part of the nervous system. So it's very important, I think, very important. And the examiners always like the cases which can integrate the concepts of anatomy with pathology and stuff. So it's very important, I think. And also you have this autonomic nervous system, so they can have some pharmacology tie in with it also. So before going to the total discussion of the Horner syndrome, the first thing we have to think about is let's think about the nerve supply to our face. So as you can remember, in our face, the majority of the nerve supply actually comes through the cranial nerves. So the sensory portion is taken care of by the trigeminal nerve. The muscular portion, especially the muscles of facial expression, are taken care of by the facial nerve. But also you have some other structures that needs to be innervated, and one of them is your eyelid. So your eyelid is actually a very delicate structure, but very important and very functional structure, and it gets the nerve supply from two structures. And one of them is the cranial nerve 3, which supplies the levator palpebrae superioris muscle. And this is very important because whenever you have a lesion of the third nerve, one of the common manifestation of the third nerve damage is ptosis, and this is because the levator palpebrae superioris is damaged, denervated, and that's why you have a drooping of the upper eyelid. But also you need to remember that there is something called a superior tarsal muscle, which is like a secondary muscle for your eyelid elevation. And whenever you have a denervation of this muscle, this can lead to a partial ptosis. Not that severe like that of levator palpebrae superioris, but it can lead to some degree of ptosis. Okay, that's the basic part here. And also inside your eye you have your iris, and as you can remember from your autonomic pharmacology and also your nervous system anatomy, that the iris has two important muscles. One of the muscle is constrictor pupillae, which is supplied by the third cranial nerve through its parasympathetic fibers. So you have the muscarinic M3 type receptor sitting on there, and you have the radial muscle or the dilator pupillae muscle, which is actually supplied by the sympathetic nervous system. So you have the sympathetic receptor, and specifically if I say the alpha 1 receptor on the dilator pupillae muscle. And this dilator pupillae muscle actually supplied by the sympathetic fibers that come from the sympathetic tract that runs from the superior cervical ganglion. So the sympathetic supply to the tarsal muscle of the upper eyelid and sympathetic supply of the dilator pupillae muscle, both of them come from the sympathetic fibers that originates on your superior cervical ganglion. And the third thing is you have some blood vessels in your face, and all the blood vessels in our body are actually supplied mainly by the sympathetic fibers. And can you tell me the type of receptor inside the blood vessels? Yes, very good. So you have alpha 1 receptors in most of the blood vessels in your body, and also in your facial blood vessels you will have the alpha 1 receptor. And okay, so that's the basic idea here. So in this picture on the right of your first aid, what you can see is you can see a basic scheme of the sympathetic supply of the face, so facial region. So actually the neurons that supply the facial region are connected to multiple series of neurons. So in that series, the first neuron is actually originating from the hypothalamus, which sits on top of your pituitary gland. So it's just above the pituitary gland, and as you can see, the name is hypothalamus. It's just below the thalamus. So in the hypothalamus there are the origination of these sympathetic fibers which run along the midbrain, can go through the pons and then go through the medulla, spinal cord, and then the synapse in the lateral horn that starts around the thoracic spinal cord segment. So this is also called the intermediolateral horn. So in that intermediolateral horn, you have the second nerve of this series, which will actually go along the sympathetic trunk, and along the sympathetic trunk later on it will synapse with the third neuron in the superior cervical ganglion. And it's very important to know the location of the superior cervical ganglion, because I had a question on NBME that a patient comes to you and she had a procedure done on his neck, on her neck, and that leads to symptoms like ptosis, meiosis, and anhidrosis. So how did it occur, or what kind of nerve fibers were damaged? So actually this girl has an operation on the neck, and this operation actually damaged the fibers that originated from the superior cervical ganglion. And as you can see here, the superior cervical ganglion is actually very closely related to the carotid vessel, especially the internal carotid vessel. And the fibers that originate from the superior cervical ganglion will actually go up, and then some of the fibers will actually go to the long ciliary nerve, and other fibers will go in different directions to innervate ultimately the pupillary dilator, smooth muscle of the eyelid called the tarsal muscle or superior tarsal muscle, and the sweat glands of the face. So this is the basic idea here. And now, as you can see, this is a long tract, so there can be damage in any part of this series, and damage to any part of the series will result in a symptom, or in the symptom group of Horner syndrome. So one of the common example of Horner syndrome is when it occurs during pica syndrome, or due to blockage of the posterior inferior cerebral artery, the damage causing the lateral medullary syndrome or the Wallenberg syndrome. All the names are same, and this is the pica syndrome. So pica syndrome can actually present with Horner syndrome too. So actually, as I am trying to make it as a very integrative discussion, that I'm trying to make sure that you never miss a question that integrates the concept of Horner syndrome, let's go back to the neurology section of the first aid and find out another part where actually Horner syndrome can occur, and that's pica syndrome. So I'm not going too detail into the pica syndrome, just it's the posterior inferior cerebral artery blockage leading to the lateral medullary or Wallenberg syndrome. And the most important feature of pica syndrome are you have the hoarseness of voice and dysphagia, and both of them occur due to the damage of cranial nerve 9 and 10. And in the pica syndrome, you can have ipsilateral Horner syndrome. This actually occurs due to damage of the sympathetic tract that coming down from your hypothalamus and going through the medulla, and that's actually causing the Horner syndrome. So remember that don't pick a horse that cannot eat. So you have the hoarseness, dysphagia, and I can also have ipsilateral Horner syndrome. So pica syndrome is one of the syndrome that you can have Horner syndrome as a part of it. Let's go to the Cavernous sinus syndrome. Okay, so next you have Brown-Séquard syndrome, which is actually a hemisection of the spinal cord. So if this hemisection occurs above thoracic spinal cord, like above T1, this will actually include the tract. So if you damage the tract, if you damage the sympathetic tract, it will lead to Horner syndrome like manifestation. And one of the next important diseases or syndrome that can cause Horner syndrome is the Cavernous syndrome. Remember that I mentioned that the tract from the superior cervical ganglia, it goes along the tract of the internal carotid artery, and then it crosses or passes by the cavernous sinus. So if there is any obstruction or thrombosis of the cavernous sinus causing a pressure development inside cavernous sinus, it can actually also lead to Horner syndrome. So I think this picture does not show it very well, But as you can see here, that internal cavity artery lies just above the cavernous sinus right here, and actually it can compress on the fibers that are originating from the superior cervical ganglion. So this is the mechanism by which it can cause Horner syndrome too. And let's get back to our main discussion. So and those are the most common neurological diseases that can cause Horner syndrome. Now let's talk about something extra neurological. And one of the most important and the most common cause of Horner syndrome is actually the Pancoast tumor. So Pancoast tumor is a tumor which occurs in the superior sulcus of the lung, and it can occur in both left side and right side. So whenever you have Pancoast tumor, this tumor actually can compress the superior cervical ganglion or the nerve fibers of the tract. I mean, compressing superior cervical ganglion is very tough because it's high up, but you can compress the second neuron. So compression of the second neuron actually can lead to a Horner syndrome-like manifestation in patients with Pancoast tumor. And we can actually see that we have already covered the Brown-Séquard syndrome and a late-stage syringomalia also. So as you can remember, syringomalia is a disease where there is accumulation of excess amount of fluid inside the central canal, which compresses mainly on the anterior commissure. But later on, you can also develop compression of the lateral horn and also compression of the tracts that run along the spinal cord. And one of the tract is the tract for sympathetic part, a sympathetic supply to the face. And if you damage this tract, it will lead to a symptom manifestation of Horner syndrome. So this is my basic idea of the Horner syndrome, and I think you will be able to identify Horner syndrome, whatever syndrome has it, and I think you will be able to answer most of the question if you have on any about Horner syndrome. So thanks all for watching my video, and I will be making more to make it very easy for you to understand everything.